Hello, my name is Basky Thilaganathan. I'm the professor and clinical director of fetal maternal medicine at St. George's Hospital in London. Today, I'd like to talk to you about assessment of fetal cardiac function and geometry. And I really need to emphasize that almost all of the work I'm presenting today is that of Dr. Olga Patey, who was my former PhD fellow and now a postdoc and a fetal cardiologist in my unit. So all credits and kudos goes to her for the work that I'm about to present. The question is, why should we really be assessing fetal cardiac function? And the answer is really quite simple. The fetal circulation is absolutely unique. There is a placenta that the fetus has to supply. There are parallel circuits, so the right and left ventricle work independently in parallel rather than in series as they do in an adult. The fetus has unique hepatic and pulmonary shunts, the ductus arteriosus and ductus venosus. And also there's principal right dominance with 80 to 90% of the work being done by the right ventricle as opposed to the left ventricle in adult life. Furthermore, at the time of birth, there is an absolutely huge change in perinatal volume and resistance load on the heart that is unmatched in the rest of human life, except probably for the time that we pass away or die. So these are absolutely unique situations that are worthy of further investigations, if only to validate that fetal cardiac function is possible and actually reflects these changes that we see in fetal and perinatal life. So we set out to study fetal cardiac geometry, myocardial strain and torsion in fetuses, and then just before birth, and then immediately after birth in the same fetuses. So in fetuses, and again in the same fetuses as early neonates, in normal term pregnancy. We want to understand the physiology of perinatal hemodynamic changes. In order to understand what we did, and forgive me if you're already very au fait with assessment of fetal cardiac function, but we broke it down into very simple paradigms. First was geometry, and I think this is understandable to most people. We were looking at the size and, more importantly, at the shape of the heart. That means the globularity of the heart, how round or dilated the heart was. Then we looked at myocardial performance here. This was using standard Doppler criteria, but instead of applying it to vessels, we applied it to the tissue. And by applying it to tissue, we can look at tissue movement profiles. And this is called tissue Doppler or tissue Doppler indices to look at myocardial performance. So you may be familiar with myocardial performance indices. We also introduced and looked at new parameters. This is called speckle tracking, and you can see that the dots here represent the movement here of the left ventricle, and it's possible to look at the speckle tracking indices and to assess strain and strain rate. That means the rate of displacement of two particular aspects in the myocardium, and that gives us an index of the functionality of the myocardium. And more importantly, as it turned out, we were able to apply this not only to look at how parts of the myocardium moved relative to each other, but we were also able to look at this in a cross-sectional way in the myocardium, to look at how twist or torsion, how the ventricle rang itself as it contracted. And this is a left ventricular twist or torsion as a function of the length of the ventricle. And these are the fundamental parameters we looked at. And we studied about 80 term fetuses around the time of birth. Just for those of you who may not be familiar with left ventricular twist and torsion, because it is not quite often done in adult cardiology, the ventricle twists at the time of contraction such that the apex twists in a counterclockwise direction. So this is the tip of the left ventricle, and the base near the atria twists in a clockwise direction. So it's rather like the wringing action of a cloth as you try and get water out of it. And the combination of apical rotation in one direction and basal rotation in the opposite direction gives us a total twist or torsion of the ventricle. Twist is just the overall summation, and torsion is as a function of the length of the ventricle, and this is what LV torsion is. The simple understanding is that the fibers within the left ventricle run in a crisscross shape, and as they contract, they cause this twisting and ringing motion of the ventricle. You will realize when I come to show you the data why it's important to understand this. So when we looked at normal fetuses, we found actually changes in a significant proportion of normal fetuses. Here you can see a more globular left ventricle in the normal term fetus compared to the neonate. Here we looked at myocardial performance indices. You can see the left ventricle MPI and the right ventricle MPI. And you can see here fetuses in blue, the myocardial performance indices were higher and dropped in the neonate, and again in the right ventricle higher in the fetus and dropped in the neonate. Here we can see the ratio of the right to left ventricle end diastolic dimensions, and you can again see uniform decrease in the RV, LV, and diastolic dimensions with the process of birth. Now, we didn't just take these three parameters, sphericity index and RV, LV, ADDs and MPIs. We took multiple parameters, and it really is outside the time of this presentation to give all of that to you. But what I've done here is to represent it in what's called a spider plot. And the spider plot shows you in pink a number of indices as it's seen in the neonate. And in blue, the same indices when measured a few days before as this neonate was in utero. And what you can see is that the vast majority of parameters are suboptimal or dysfunctional in the fetus. And very soon after birth, within hours to days of birth, they become corrected and become normalized, okay? And the conclusions we came to was that the perinatal period, especially in the fetus, is associated with fetal cardiac geometrical, myocardial performance, and ventricular function changes in these in fetuses, which then normalize soon after birth. Now, so far, there was a range, and we presumed that because the fetus was normal, everything was okay. These parameters reflect normal fetuses. Then we started to look at the twisting motion of the fetal left ventricle. Here you can see the normal adult type motion, and as I described to you, anti-clockwise and clockwise. So anti-clockwise in the apex and clockwise in the base, and that's the normal twisting motion. There are long known that in the infant there is this common anti-clockwise rotation of both the apex and the base, and that's well recognized in infant cardiology. So we knew that we might see normal adult type, and we knew that a percentage of fetuses would have an infant type twist pattern as well. And these we were expecting. And that's exactly what we showed in the neonate, that a proportion of these normal neonates had adult type twist patterns, and a proportion of them, about 40%, had this infant type twist pattern. What we did not expect to see was that when we looked at these same neonates before birth, about 15% to 20% of them had what was called a reverse apex type rotation. Yes? So the opposite of what we would expect to see in the infant type. The reason this is particularly important is that this reversed apex type rotation, certainly in adult life, is extremely rare and is only associated with severe cardiac dysfunction. For example, it is seen in dilated cardiomyopathy. And this was really quite an unexpected finding, that we were seeing in a proportion of apparently normal fetuses some reversed apex type rotation. And the question we asked ourselves is, well, is this just a random feature? Or is the presence of unusual rotation in these fetuses associated with the functional indices? And that's exactly what we found. We found that the reversed apex type rotation was more likely to have suboptimal cardiovascular indices. But these were all still in the normal range, but the indices associated with these aberrant red dotted things were more likely to have normal. And you can see that the infant type indices always had good parameters or good cardiovascular indices. So our question here was really quite important. We found that in some fetuses, in apparently normal pregnancy, they exhibited suboptimal geometry myocardial strain, and it's associated particularly with a reversed type, apical type twist. And these features almost entirely recover soon after birth. So we did not see that aberrant pattern of twist and torsion, and almost all of the features were normalized after birth. And what we did not know was whether indeed this apparent dysfunction is normal in normal fetuses, or whether it is secondary to occult fetal hypoxemia at term, a feature that we know can occur. So we decided to take on the second aspect of the study, and we moved on. A secondary study to look at fetal cardiovascular function in pregnancies with known fetal growth restriction, therefore placental dysfunction leading to small or poor growth, as well as indices of hypoxemia. And what we did was we wanted to relate the cardiovascular functional indices we saw with markers of fetal hypoxemia, as well as pregnancy outcome. And here, we need to understand a little bit more about placental dysfunction. It is common for us to use the term fetal growth restriction, which is a restriction of growth or a change in the size, inability of the baby to increase its size as pregnancy goes on. The problem with this term is that it relates only to nutrition. Lack of nutrition leads to poor growth. And that is a symptom of the disease and not the disease. The disease is placental dysfunction, the pathology, and the symptoms may be poor growth, growth restriction due to poor nutrition, or maybe death and disability due to poor oxygen supply. And here it is important to realize that we may have a baby that's normal in size because nutrition is being met, but it may still suffer the consequences of death and disability as a consequence of hypoxemia rather than malnutrition. And therefore, we must understand the disease is placental dysfunction. The symptoms may or may not be poor growth and disability and dysfunction. Another way to look at it and understand it is to realize that the nutritional demands of a fetus and the oxygen demands of the fetus are not parallel. They take a different curve. Here in green is the nutritional demands of the fetus, and it's very familiar to you because it represents the growth curve of the fetus. But in red is the exponential metabolic demand increase of a fetus. And here it becomes really easy to understand the consequences of placental dysfunction at different times. If the placenta fails early, when nutritional demands are increasing exponentially, as it's shown here, then the consequence of placental dysfunction will disproportionately affect the size of the baby through lack of nutrition. But because oxygen demands are fairly stable, it is unlikely to result in severe hypoxemia or death and disability. However, if placental dysfunction occurs at term, then the consequences on growth may be too little because the baby has already reached 3.2 kilos. It can't shrink. It may just fail to grow to 3.4 or 3.6 kilos. But at this stage of the pregnancy, oxygen demands are increasing exponentially, and placental dysfunction at term may result in death and disability in a short time frame rather than a longer time frame. And we showed this, and we certainly showed the importance of the distinction between nutrition and oxygenation by looking at CPR. CPR here is the ratio between cerebral blood flow and umbilical artery blood flow, and therefore a marker of redistribution or brain sparing in the fetus. And we looked in a large cohort of pregnancies and in a sub-cohort of 3,000 pregnancies to look at the association between fetal size as well as redistribution and perinatal death. And here you can see that both birth weight centile and redistribution CPR multiple of the medians were both significantly associated with perinatal death. However, these are individual statistics. And when one does multiple regression yes, a multiple logistic regression, one finds that it's only CPR that is continually associated with perinatal mortality, but not birth weight. So the conclusion of the study was that CPR, a marker of hypoxemia, was associated with perinatal mortality, but not fetal size. It was not just our work. So here is a systematic review, 22 studies, 4,300 women, where they looked at multiple parameters. And what they showed was that the use of CPR, or fetal oxygen redistribution, had a very high sensitivity and very high specificity for perinatal mortality. So what happened? We looked at 33 fetal growth restricted fetuses, and not surprisingly, we found very similar characteristics. Yes, a more globular heart in the fetus. We found left ventricular sphericity index here. You can see in the fetus of the fetal growth restriction, a more globular fetus compared to a normal one. And in the neonate, exactly the same. The globularity persisted into the early neonatal period. The same thing was true of longitudinal strain. Again, you can see normal and fetal growth restriction in the fetus, poorer longitudinal strain or lower longitudinal strain, and the same here in the neonate, a persistence of aberrant strain indices. Again, we can see in the spider plot here, and here we're not comparing neonates to fetuses, we're comparing fetal growth restriction to normal fetuses. And you can see that in all of the parameters, the indices were aberrant in fetal growth restriction in red compared to normal fetuses. Again, arbitrary indices. Again, the left ventricle being predominantly affected here. What about torsion and twist? And here, again, very interesting findings. We found that left ventricular torsion, as expected, yes, poorer in fetal growth restriction, and a persistence of poor torsion in the neonate, fetally growth restricted neonates. When we came to patterns of twist, very interestingly, in the fetus, we saw very little change. Yes, we saw similar rates of adult, a little bit more infant, and here you can see reversed apical twist here, and a similar proportion of fetuses with reversed apical twist. Unlike normal pregnancy, there was a persistence of reversed apical twist in the neonate of fetal growth restricted infants. So it seemed that there was some degree of aberrant myocardial function that persisted into the neonatal period. Now, the $64,000 question was, were these changes that we saw related to hypoxemia or not? And the answer is absolutely yes. And the most interesting finding is seen in these two slides here. This is the left apical systolic rotation, so the degree of apical rotation, and here is TAPSE, yeah, a very simple index of myocardial function, and here is MAPSE, tricuspid and myocardial. So here we have CPR MOM, and what one needs to realize is that the lower the CPR is, the more hypoxemic the fetuses is. And here you can see the relationship here, that the fetuses that were most hypoxemic were the ones that had the reversed apical twist, the aberrant twist pattern. Whether we were talking about apical rotation, whether we were talking about tricuspid function, or whether we were talking about mitral valve function, all of them showed that the babies with the abnormal twist and torsion were the ones that were most hypoxemic. So fetal growth restricted fetuses with low CPR reveal signs of deterioration in myocardial contractility, suggestive of limited cardiac reserve and possible decompensation. So I'd like to finish with this aspect. What we've shown in our series of works, and there's subsequent publications, is that the assessment of fetal cardiac function is technically feasible, possible, and accurate. And then we showed technically that fetal cardiac indices accurately reflect myocardial responses to hemodynamic load and hypoxemia, whether we were talking about the significant changes that occur around the time of birth, or whether we were talking about fetal growth restriction. And in terms of the pathophysiology, there is evidence of occult hypoxemia at term, even in apparently normal pregnancy. So these babies that we call normal because their size is okay, a small proportion of them have occult hypoxemia as evidenced by poor cardiovascular functional indices and aberrant twist and torsion patterns. And that proportion is much higher if we have identified fetal growth restriction or placental dysfunction. The fetal cardiac indices reflect the severity of hypoxemia, as shown by the CPR. And very importantly, the fetal growth restriction fetus, out of 33 fetuses, there were 4 perinatal deaths because of the severity of growth restriction. All 4 perinatal mortalities in the fetal growth restriction cohort all had reversed apical twist, yes, and poor myocardial functional indices. So it accurately reflected the babies that were going to die. Fetal cardiac indices typically recur in the neonatal period, and that was certainly true of all of the normal pregnancies. But a proportion, as you saw, of the fetal growth restriction neonates had persistent aberrant cardiac indices and twist and torsion patterns. And our current project is to look at these babies in a longitudinal fashion in early infancy to see how it goes. On the top left, there is Olga Patey, who, I cannot anything but commend her dedication and hard work to this. And of course, my collaborator, Jelaine Carvalho, without which all of this work would not have been possible. I apologize if I confused you about twist and torsion. I have to admit it was extremely difficult for us as well. And those 3 cones represent the conceptual beginning of our work, where we suddenly realized that we were seeing these 3 patterns of twist and torsion, which I believe will be fundamentally very important in the future. Thank you very much indeed.